Okay, so I applaud you for what you're doing and encourage further advances. So we have I-ELCAP, which and the research objective is advancement of knowledge of optimal treatment for clinical stage 1 lung cancer. You can see that there are many topics from the cases that David showed. So we've published on lobectomy versus sublobar resection, surgery versus radiotherapy, staging of mediastinal lymph node, and right now we're working on comparison of clinical and pathologic stages of stage 1A lung cancer. So this is a prospective cohort of patients at our institution, which has 7 hospitals. It was originally collected with the 8th TNM, but we've upgraded it to the 9th classification. We look at quality of life, background, exercise. We're working on papers on all of the treatment considerations by the treating physician, and we have follow-up every 2 months after treatment completion, and then at 6 and 12 months intervals thereafter. Initially, we had done a pathology review, which was generously funded by Robert Smith from the American Cancer Society, and we reviewed all of our early lung cancers that we found in our initial study. And that led to a lot of publications, but also recognition of non-solid, part solid, and solid nodules, and also led to changes in the pathology descriptors, because the pathologist said, oh, these are cancers, but they're different from anything that we've seen before because they're so small. So that led to really the changes or the designation of atypical adenomatous hyperplasia, adenocarcinoma in situ, minimally invasive adenocarcinoma, and then invasive adenocarcinoma with predominant findings. And I think these insights will continue to develop and will change the workup paradigm and the treatment paradigm, as you saw. So currently, as I said, we use the 8 staging classification, but we're now reclassifying everything according to the 9th classification. And we wanted to know the agreement, first of all, with clinical stage 0, 1A patients and pathologic stage, and then also look at the subcategories. So here's what we did with 827 patients with cancers that were classified by clinical stage 1 and pathologic stage. So let me focus on, first of all, those in pink that you see are clinical stage 1A patients that were also classified as clinical pathologic stage 1 patients. So you had 653 were classified as pathologic stage out of the 827. So the agreement was really rated as excellent because it was 79%, although the kappa values were a little bit lower, showing fair agreement. And overall, none of the non-solid cancers had lymph node or distant metastases, and under and over staging occurred in 14.4% and 21% of the patients. Let me just go back for a moment. Really mainly due to tumor size discrepancies, unrecognized pleural invasion, and additional non-small cell cancers. So for these clinical subcategories, however, there was very poor agreement, and it's tabulated here, but let me show you here. So out of the 53 clinical TIS, only 5 of them were remained classified as a pathologic TIS. Of the clinical T1A, 57% were classified as P1A, And then for the clinical T1B, it was 54%. And for the clinical T1C, it was 31%. So all of those are less than the 60%, which was, so they're rated as poor. So this is just a summary of them. Most of them, so we had overstaging in 119 of the 827 cases. All were due to the patient having a smaller pathologic invasive tumor diameter than the diameter measured on the pretreatment CT. And the details are shown here. Clinical overstaging, or this again summarizes the clinical overstaging. You see that in pink are the ones that were reclassified. So 326 of the 827 cases were understage for the following reasons. 152 patients had pathologic invasive tumor diameters that exceeded the pretreatment diameter. 131 remained as N0, M0, but had local invasion of the pleura and therefore classified as a higher T category. 39 had lymph node metastases, but were still M0, and 4 of them were classified with pathologic metastatic disease due to in malignant pleural and pericardial effusions. So the survival is important. So we don't have long-term survival yet, but you can see the survival by the 4 clinical stages is very close. There's some separation, but they're really very close together. And the survival by the consistency of the tumors, non-solid, part solid, and solid, also were pretty close, but showed some separation. So we now are reviewing the recurrences both of suture line and multiple cancers, multiple other cancers that are diagnosed, and we need longer follow-up times to get better survival rate. Thank you.
So Claudia, I have 2 questions. One is just very practical. The I-ELCAP, you have a rich data source. Would you be interested in contributing to the 10th edition cycle?
So these are I-ELCAP patients. They're all patients that are treated, not necessarily found by screening, but so we have that database. We can discuss it. We'd have to get consents of the IRBs and so on, but we really want to collaborate. So we'll figure out how best to do that. Yeah. And we have a very enterprising Louis Gros who's been working with us, and we have 3 publications really that submitted or either accepted.
And this is an ongoing cohort, right?
This is an ongoing,
yes.
Yeah. And actually, we want to have Eric Tunison and our pathologist who trained under Travis spend time together about 1 week reviewing all of the cases and really coming up with and I think, let me just put in a plug for the anatomic unit of the of the lungs, which is a secondary pulmonary lobule, and I think we need to think about that lobule and its in the staging classifications for these small lung cancers.
Great. The other thing I was going to say is in the 10th edition, we're very interested in looking at the question of radiologic and pathologic invasiveness versus not. So we really want to test radiologic solid versus non-solid components, which of them really should be incorporated in the staging system. We have recommended that it should be the solid part, but we've never really tested the veracity of that recommendation.
So we really think that it may be that the radiographic appearance is much more predictive than the current pathologic class of these small tumors.
Yeah, so we would be, I think there's good reason to want to collaborate.